Well, good afternoon, everybody. I was just saying, I hope you're enjoying the music, and then it came to an end. But I guess all good things do have to come to an end. So, but we are going to be starting something that will be another good thing. So, anyway, it's good to have everybody back after the summer. I hope everyone had a nice summer, and we're excited to have Dr. Nolene Jeffers here today, who's going to be kicking off our Health Equity Jam session series for this academic year. So the first thing I want to do is to make sure that you all know that we are going to have a survey link that gets put into the chat, so that you can share your experience with the Health Equity Jam session when you get a chance. And now we're going to move into our usual fun facts introductions and an introduction of our speaker for this afternoon. So I don't know how many people know the song that we just heard. Yeah, Jerusalem. I love that. How many people know the dance? Oh yeah. Well, I see a few people. Too bad we're not in person. One of these days we'll do a hybrid session, or maybe we'll move back to in person, but we have so many people from all over now. We don't want to, exclude you guys. So it'll end up being a hybrid session, but then maybe we can do the dance. So I see some folks were having a hard time doing that dance. It can go on for a while, and then it's like, wow, you figure out how much, whether you're in good shape or not. So anyway, but here are some fun facts about our speaker. How many people know where she hails from? Where in the world is Dr. Nolene Jeffers from? Guesses? Nobody, no personal friends get to join in on this. So you can put your answer in the chat, or if you want to come off mute and say it, that's fine too. Any guesses? No clues from the name, right? Nolene Jeffers. Well, okay, somewhere in the Caribbean. The West Indies. How are you people so smart? She is from St. Croix, an island in the U.S. Virgin Islands. So bravo. Yeah. So we have someone hailing from the U.S. Virgin Islands, which is a place I would love to be at any time. She's got some interesting favorites in terms of the movies she likes to watch. I know my husband thinks I'm boring because I watch period pieces and romantic comedies, and everything else is kind of like too nerve-wracking for me. Like those action-packed films and those scary movies, they're just like not my thing. But anyway, how many people want to guess what Dr. Jeffers, what her favorite type of movie is? Comedy. Okay. Thriller, Marvel, sci-fi, drama. Let's see how many votes we get. Well, I have two comedies, and thriller and horror, I guess, are the same thing. Is drama the same as horror? So we got a tie between comedy and thriller horror. What's the winner? Oh, we got another horror. Okay. Well, her favorite type of film is, you want to tell us about your favorite type of film, Dr. Jeffers?
Sure. So I love zombie films and post-apocalyptic films. Anything where the world is ending, people have to survive. World War Z, I love that movie. Yes.
Okay.
I have no idea why, but just very drawn to those movies. So
Well, it's probably why you're like interested in solving a problem as complex as health equity, right?
yeah.
But anyway, that's interesting. See, I look at all these different suggestions for different movies for you. Fallen, Train to Busan,
Yes, I've seen
Sweet,
some of them.
The Last of Us on HBO. Yeah, there's so many of them.
That's
I
a
don't know
good
what
one.
don't know what that says about us, but but anyway. So, okay, there's one more fun fact. We all have different sort of hobbies and skills, right? Some of us play musical instruments, some of us do sports, some of us have other talents. What is something that Dr. Jeffers does in her free time that is a sort of a hobby that also involves some skill? Pickleball, singing, all of those things are interesting. Pickleball, singing,
Done
crochet,
pickleball once.
okay, knitting, gardening, writing. Okay, well, we've got some sort of winners here, right? Which winners would you pick?
Well, it looks like Yvonne got it right,
That's
knitting.
great. Yes.
Um, and so I learned how to knit in midwifery school. So a lot of midwives know how to knit. And it's not something that I really like actively do anymore, but we as midwives like to say, in order to keep the birth going normally, to prevent yourself from intervening and causing harm, um, when you didn't really need to intervene, you do something with your hands. You sit on them or you knit.
Hmm.
So a lot of us learned how to knit in midwifery school. So yeah.
Interesting. That's something I never knew. I bet Dr. Commodore Menza knew that from being going to nursing school.
I-
No?
So,
Okay. She's just smart like that.
oh,
Okay.
okay.
Well, Allison Trainer was kind of close. She said crocheting, but so yeah, great, great. Well, that's really interesting. Well, let me tell you like more formally about Dr. Jeffers and then let her get into her talk. Oh, sweet idea. You can make hats for the babies you deliver
Mhm.
too.
Yep.
So Nolene Jeffers is an assistant professor at Johns Hopkins School of Nursing, and she's a certified nurse midwife. She's had over 8 years of experience serving families in federally qualified health centers, hospitals, freestanding birth centers in Washington, D.C. And in her research, she uses reproductive justice and Black feminist thought frameworks to examine the socio-structural determinants of Black maternal health outcomes and to design innovative and culturally relevant interventions grounded in the needs and strengths in the Black community. Um, I don't know how much more you want me to say, Nolene. I don't want to steal all your thunder. Your bio says a lot about what you're currently doing. Do you want to wait and tell them about that in your talk, or would you like me to tell them?
Yeah, I can share about it in my talk.
Okay, so I think I'm going to let her tell her story about all the interesting research she's doing and the interventions she's designing and the partnerships that she has established in her work. So we are thrilled to welcome Dr. Nolene Jeffers to the Johns Hopkins Center for Health Equity Jam session. Take it away,
Awesome.
Dr. Jeffers.
Thank you. So I'm actually going to work on sharing my screen. So you should see a blank screen, and shortly you should see some slides. Okay. Can everyone see my slides?
Yes, we can.
Awesome. Wonderful. Well, thank you, Dr. Cooper, for inviting me to speak. It's really great to be here, and thank you for the introduction. And I'm excited to talk with all of you today to share with you my research and this talk, Redesigning Systems of Care to Promote Equity in Black Maternal Health. So this talk today is really highlighting my past and current research. But I think it's important to know that research is sort of just one way, one part of my life, one part of sort of a long career in which I've been working towards promoting Black maternal health. And I want to share a little bit about how I got here, because this journey has really shaped who I am and also my research. So as Dr. Cooper mentioned, I'm from the Virgin Islands. I feel like more and more people know where that is now, but I always like to share a little map. So you can see in the bottom left, a lot of people know sort of Cuba, Jamaica, Haiti, Dominican Republic, Puerto Rico. Um, but here we are, the Virgin Islands, tiny little islands, and I am from St. Croix. It's down here, the largest one. And I grew up there. I was born there, grew up there, and was there for the first 17 years of my life. And so, like I mentioned earlier, your journey really shapes who you are and also your research. And so, for me as a young child growing up on an island where most people look like me, most people were Black, there was a lot of pride, a lot of cultural pride, and there was a lot of ease that comes with that. And yet, things weren't perfect, right? We're a US territory. There's, the vestiges of colonialism, they're still present, being sort of a second-class citizen. You're not able to vote for president. There's differences in Medicaid and insurance benefits. And so these were all things that were talked about at the kitchen table, but it also motivated the political consciousness of sort of the larger community, and their conversations that really started to shape my worldview. Now, the pictures here are very benign. Most of them are of my son and my dad. And this was on, I think, our first, or maybe our first and our second trip back, or his first and second trip back home when he was 1 and 2. So there's him on the beach, enjoying the beach. He's there with my dad. My dad's cracking open some dried coconuts, and my son doesn't see this stuff, right? So he's really enamored by anything really my dad does. And then my dad's showing him our yard where, and my parents grow a lot of fruit trees. Um, so yeah, so this is a little bit about me and where I'm from. And so then after so when I graduated from high school, I wanted to come to the States. And I came to DC. And so, funny enough, my mom, who was a teacher at the time, she was like, "You can go away, but if you want to be a nurse or a teacher, you just need to go to the university here because there's just no sense in us sending you away. Like, we do those things fine here." And I was like, "Oh, no, no, that's not what I want to do." Um, and so I went to Georgetown and I studied international politics, and did not do that at all. I ended up becoming a nurse and a teacher in higher education. Um, but you're on the path that you're meant to be on. But really, when I graduated from college, I felt like I needed a skill, and I was thinking about nursing, but wasn't quite sure, and also considering uh, medical school, and started to learn additionally a little bit about midwifery. And so I shadowed physicians and midwives, and um, I shadowed this one midwife. She had her own practice, and they did births at home births, and also hospital births. And I was just blown away. I was like, oh my gosh, at the end of the visit, I'd never seen anything like it. The love, the care, the respect. I was like, this is what I'm supposed to do. So I decided to become a midwife. And so I went to Yale, and 3 years later, I was a nurse, I was a midwife. It's a very efficient program. And so this is actually a picture of me towards the end of my studies in midwifery program. We have this ceremony. A lot of midwifery schools do it. It's called the blessing of the hands. In midwifery, hands are just so important to what you do. They're crucial, right, to being a midwife. And so we do this ceremony where your hands are blessed before you finish up your last semester of midwifery school. And it really just sort of honors your entry into a really historical and privileged um, profession. So once I graduated from midwifery school, I moved back to DC, and I practiced as a midwife at two federally qualified health centers. So first I worked at Community of Hope, which has a birth center in DC and also does hospital births. And then I switched over to Unity Healthcare after 3 years. And so for many years, I really practiced as a community midwife. I lived in Northeast DC. I lived in the same community as my patients. I had a family across the street that I cared for. I'd see them in the grocery store, the laundromat. I would never sort of say hello to them. Well, the family across the street, I always said hello to because we sort of developed a nice rapport. But when I saw my patients, if I didn't have sort of a long-standing relationship, I wouldn't, you know, I want them to sort of recognize me, not me initiating any conversation with them. So, but oftentimes they said hello, or they'd say, "I haven't been to see you in a while. I need to make an appointment." And so it was a nice, experience providing care in a community, and not just pregnancy, birth, and postpartum care, but really well-person care, thinking about birth control, gynecologic care as well. But as the years went by, I really saw some concerning patterns, right? So, I'm a midwife in the nation's capital, and it's really clear that a lot of patients didn't have basic needs met on a consistent basis. Um, and it got me asking questions. Why is it so difficult? And it wasn't an individual struggle, right? It seemed to be something impacting the larger Black population in DC as it pertain to concerns with transportation, secure housing, job security, income security. So I could see how these factors were also impacting outcomes, increased rates of preterm birth and low birth weight. And by the time someone saw me, I wasn't sure that there was much that I could do to reasonably reduce the risk of an adverse outcome. And I really wanted to know, how could I change their trajectory to be more positive? And really, how could I intervene a little bit earlier? So I decided to get a PhD here at the School of Nursing, um, also did a postdoc at the School of Public Health, and then came back to the School of Nursing as a faculty member full time. And so the last few years, I've really been entrenched in academia, but I also do quite a bit of advocacy work as well. So I'm on the board of the National Association to Advance Black Birth, which is a nonprofit whose mission is to combat the effects of racism on Black maternal and infant health. And we actually created something called the Black Birthing Bill of Rights, which is really developed to help patients sort of understand the standards of care that they should be receiving. And it's a tool that they can use to help advocate for themselves. But as we grow the Bill of Rights, we really hope that also hospitals, health departments, governments will really understand the standards of care that they should be providing um, as well. So this is also sort of a part of my general work and my contributions in this field. But I really, wanted to introduce myself because it sort of gives you an insight into parts of myself, my identities that really influence my life, the lens through which I see the world, um, and my research, right? And so when I approach my research, I'm really reflecting and staying mindful of how my social positions really impact the research process, research participants, and implications for the research as well. And so a few of the things that you probably took away, I'm a Black woman, I'm a mother, I'm also a first generation American because my parents aren't from the Virgin Islands, they're from another little island. Um, I was born and raised in a US territory, I'm a midwife, I'm a researcher. So all of these things impact the research that I pursue and also how I conduct it as well. And so for today's talk, I really have two objectives. I really want to discuss one, what motivates us, me, all of us, to research Black maternal health. So thinking about sort of the events, the trends, the systems and structures, and the mental models that contribute to the state of Black maternal health right now. And then second, a little bit of a window into my current research on redesigning systems of care to promote Black maternal health equity. So I really love this framework from AMCHIP. That's the Association of Maternal and Child Health Programs. They hosted a systems mapping framework with a really large group of diverse individuals and organizations, sort of representing Black, Indigenous, Latinx led community and perinatal support organizations, health departments, higher education institutions, and policy organizations. And it's based off of the iceberg systems framework, which helps us to think about how we can approach systems change. And so I'm just going to sort of review the different levels, just in general, and then also how it relates to Black maternal health. So the event level is sort of the level at which we typically perceive the world. So maybe it's a harmful interaction between a healthcare provider and a patient. Maybe it's an adverse clinical event. But events are really just sort of the tip of the iceberg. And the iceberg model really urges us to consider that events can't be solved simply by treating symptoms that are most visible. So underneath events, then you have trends. So these are sort of similar events that have been taking place over time. So in the case of Black maternal health, we're seeing that despite maybe periodic reductions in national rates of infant mortality, we actually see that racial disparities in infant mortality still persist. And so observing trends can allow us to predict events. And then the system structure level, which is really what's causing the trends that we see. And these are things like organizations and institutions like hospitals, professional healthcare organizations, policies, and whatnot. And then finally, mental models, which are our attitudes, beliefs, morals, expectations, values. And these sort of allow, first they help to create the structures, but also allow them to continue functioning as they are as well. So they might include things like patriarchy and racism and whatnot. So I'm actually going to sort of review a little bit more about this and starting with some of the mental models. So when we think about prevailing mental models in perinatal care, we can think a lot about sort of the biomedical model, which is very hierarchical. You have nurses and midwives who are generally sort of under physicians. The general prevailing model is that childbirth is pathological, inherently risky, should take place in a hospital. And then I added this part in with the physician, very focused on technology and intervention, on objective versus subjective data. And it's, again, really grounded in institutions. So taking people outside of their home to receive care in clinics, health centers, and hospitals. Another prevailing model is gendered racism. So this particularly impacts Black women, right? So one example of this is the welfare queen, which was a term that was coined by Ronald Reagan in the 1980s when he was campaigning for president. And it really sort of played on society's views of Black women as lazy, hyperfertile, and unable to lift themselves up by their bootstraps, a burden on society. And really just this term really just describes the ways that Black women can be harmed by the intersection of racism, sexism, and classism, often leaving them feeling judged, which might actually impact their behavior, their willingness to seek care, and their outcomes ultimately. So in terms of system structures, there's lots of structures that we can talk about. I really just wanted to touch on the structure, thinking about sort of the perinatal workforce. And because I'm a midwife, I'm really interested in the structure of midwifery and the midwifery workforce. And so in my sort of own research, I've learned that, sort of the current midwifery landscape, the current workforce for perinatal health is really a large result of systematic efforts in the mid-20th century to eradicate Black midwives. So Black midwives basically had their own businesses where they cared for individuals and communities, really well respected, well regarded women in their communities, and who also earned a living, right? So they charged oftentimes for their services or maybe bartered as well, but sort of had this independent economic viability for themselves as best as they could. But as sort of OBGYNs were creating a new profession, what we find is that they, along with, particularly white OBGYNs, along with white nurses and health department officials, public health officials, really started sort of a racially motivated regulation of Black grand or granny midwives, trying to steer both Black and white women out of the care of Black midwives and into hospitals, which were sort of this new um, thing that was created that needed to sustain itself. In what other way of sustaining itself by having, basically half of the population in the United States that was going to need to birth a baby in their institutions and under their care. Um, and and what ended up happening is that many Black midwives, not all, but many were sort of pushed out of midwifery. And instead of sort of midwifery really grounded in the community, midwifery became sort of nurse midwifery and very much tied to nursing. And thus, because of that hierarchical structure that I talked about earlier, under physicians. And also very much a largely white profession, not completely, but largely. So today, midwives attend about 12% of all births they did in 2021. And so that's moving up slightly. It used to be 10%. So there's been some increase there, but that's a far cry from what it was. In the early 1900s, Black midwives were caring for as many as 90% of the entire population, regardless of race, in the South particularly. So there's really been a lot of changes. And then this is a sort of a great map because it helps you see sort of, what's the integration of midwives today. And so the levels of integration are depicted by the darkness of each state. So the deeper shades of purple really represent higher integration of midwives. So meaning midwives will typically be a higher percentage of the perinatal workforce. They may have independent practice regulations and laws in that state. So there's just less barriers to entry and to practicing independently as a midwife in states that are colored sort of the dark purple. And those states also tend to have, by and large, better perinatal outcomes as well. And so currently, when we, again, still thinking about systems and structures, our reimbursement models for insurance, Medicaid, limitations on licensure, scope, practice, prescribing, lack of knowledge of midwifery, lack of access. These are all sort of pillars that sort of maintain a very homogenous perinatal workforce, which is very different from a lot of other countries in Europe, and particularly when I think about sort of the United Kingdom, where everyone pretty much gets a midwife. And some people also get a physician, right? So this idea that midwifery, everyone needs that type of care, and some people also need an additional level of care as well. But here there are many, many barriers um, to sort of changing the workforce, the perinatal workforce. Okay. And then finally, we have events and trends. And so I'm sort of going to cover those together because, it's kind of difficult to keep them apart. But again, sort of what are the outcomes, experiences of care, and how do trends and disparities show up in Black maternal health? So this was a study by the CDC. There's also a very similar one by the Birthplace Lab as well. But, this is sort of one of the tips of the iceberg, thinking about how people are treated, how they experience their care. And so, when we talk about mistreatment, we're talking about things like being ignored by your provider, being refused a request for help, failing to respond, having your provider failing to respond to a request for help in a reasonable amount of time, having your privacy violated, particularly during vaginal exams and whatnot. So these are different things that everyone is really experiencing, but as you can see, it's not a homogenous experience. So Black women, almost a third are saying that they experience mistreatment during maternity care, and certainly individuals who have no insurance or who have a public type of insurance are also experiencing these as well. And so lately, a lot of this, there's been a lot more fervor, I should say, around sort of solving what's often termed as a crisis, even though sort of it's really constructed in very much a systematic way of how we deliver care. And so lots of articles, you'll see them all over in the New York Times and NPR and whatnot that really sort of highlight a lot of the physical outcomes too, right? So we have differentials in maternal mortality rate by race as well. So you can see here that Black individuals, so these are maternal mortality rates in 2021 and 2022. And you can see that Black individuals experience between um, 2 to 3 times the maternal mortality rate as white individuals. And there are, of course, other groups that are missing from this, but because maternal mortality generally occurs in small numbers. In smaller populations, it can be hard to generate reliable estimates. So that's why you may not see groups like American Indian each year sort of having a reliable estimate. And then again, I mentioned sort of how this is in the news. And when we think about outcomes, Serena Williams was really open about sort of her near-death experience and how her concerns around potentially having blood clots in her lungs were ignored. And then Tori Bowie, who was an Olympic athlete, she died of eclampsia. So it's really, you know, no Black woman is really immune from these experiences of care, these poor outcomes, which are oftentimes due to those mental models that I talked about earlier. All right. Okay, so I would love to spend sort of um, some time now thinking about or talking about the kind of research that I'm undertaking in areas that contribute to systems redesign. So when I think about redesigning systems, I think about doing it in many different ways, and I've tried to do some policy-oriented research. I've also really focused on partnerships between community models of care and healthcare systems. And then finally, also working on intervention design. And so some of this research has been completed and might be in the dissemination phase, and other parts of it are really ongoing, but I'm going to share that with you now. So the first area that I'll talk about is policy-oriented research. So these are really just some examples of papers that I did recently related to housing and Black women in Washington, DC. And so we partnered with the DC Health Office of Health Equity, also with Community of Hope, my former employer. I haven't worked there in many years, but we partnered with them to conduct a qualitative study describing the experiences and needs of Black women who are experiencing homelessness during pregnancy in DC. And so we worked with them on a working paper that is published on the website, the DC Health website. We also just published our first peer-reviewed paper as well. And then we should be submitting a second paper for a special issue later this month. So we're working on getting that paper ready for submission. The overall objective was grounded in a reproductive justice framework. We sought to explore the lived experience of people who have experienced homelessness during pregnancy in DC to inform policy. And so I just want to talk a little bit about sort of reproductive justice. And in my work, I would say that I have increasingly tried to utilize frameworks and models that are created by Black women, Black individuals, people of color, who really have sort of this unique position in society and unique lens. And so reproductive justice specifically is a human rights framework, and it addresses the full spectrum of reproductive oppression, and it's really grounded in the historical and lived experience of Black women and people in the US. And at the same time, it is also it was also meant to be transnational, so it can be really extended to anyone. But it was created by Black women here in the United States based off of their experiences. And so reproductive justice really upholds the right to have a child, the right to not have a child, and the right to parent the children that we do have in safe and sustainable communities. And so around the time when reproductive justice was developed, the reproductive rights movement was really at the forefront of sort of, the American psyche. And it was related to an individual's right to privacy, choice, access, and primarily concerned with the right to not have a child through abortion. But for Black women, reproductive justice really addresses sort of the historical assaults on Black women's reproductive autonomy, which is not just about abortion restrictions, but also included restrictions on having a child. And so there was this long history of forced and coerced sterilization that also needed to be addressed as well. So that's why you will see that the first tenet is the human right to have a child. And then, of course, the second tenet that is included relates to abortion as well. And then finally, the third tenet really speaks to the long history of Black communities being intentionally marginalized economically, deprived, which really makes it difficult to raise a child in a nurturing and loving environment. And so when we approached this study, we really saw housing as a reproductive justice issue. Housing impacts the choices that we make around deciding if and when to start families. And deciding, like, is this a safe enough and stable enough housing situation in which to have a child? So housing impacts people's decision making around their health, their reproductive life. And so housing is really a reproductive justice issue as well. And so this is just a reminder sort of the partnership that was created in this study. I think I mentioned that we partnered with the DC Department of Health, Office of Health Equity, the nonprofit Community of Hope. And Community of Hope, in addition to providing health services, they also do a lot of homelessness services as well. And so they received funding to conduct a number of smaller research studies that were subsumed under something called the CASI sort of project, or Calling All Sectors initiatives. And it really tried to understand what were the levers of change for improving health by improving other sectors, social sectors like housing, transportation, job assistance, things like that. And they really hoped that the findings could be used to address housing insecurity among pregnant residents, to ultimately improve birth outcomes in DC, through policy and practice changes. And DC is a particularly interesting sort of microcosm because Black individuals definitely have significant disparities and inequities. So higher rates of preterm birth, low birth weight, infant mortality, also maternal mortality, even though I don't have that on here, as it compares to white individuals. And also Black women and anyone who can become pregnant actually represent 82% of the adult population in families that are experiencing homelessness in DC. And so there's a thought that there is some overlap, some intersection between two um, uh, these two circumstances. So we did a qualitative study with 20 Black women in DC, aged 18 years and older, with current or past experience of homelessness during pregnancy, in-depth interviews. We use content analysis. And so I'll present some of the findings. I didn't want to put too many quotes, so I think I only have a couple, but I'll share some of our lessons learned and some of the policy recommendations that we made as well. So one thing that we actually learned, and our study was really interesting because there's really very little research around homelessness and pregnancy, particularly with people that are currently experiencing homelessness, and pregnant or who were. So providing this data to policymakers was such a great opportunity to provide them with information that they needed to make structural changes, redesign systems, and improve the homelessness support that they gave to pregnant people experiencing homelessness in Washington, D.C. And so one of the things that our participants really talked about was, hey, I was unable to access structured housing help until the third trimester. And that was a policy of the housing system. And so one of our recommendations was, ensure meaningful access to people who are pregnant and eliminate barriers that impede timely access. So waiting until you're 28 weeks to receive help to be housed is, really just untenable. It's just really challenging. There are risks in other trimesters of pregnancy. And there's also an argument to be made that, hey, if you actually intervene earlier, putting people on sort of, a more stable path, then perhaps that could improve outcomes as well. Um, we also learned that participants experience a lot of complex homelessness verification requirements that were a barrier to access. Um, so, if you were on anyone's lease, you could not get housing. Um, and you had to prove that you were off of the lease in order to be able to get housing. But as we all know, just being on a lease doesn't mean that you have a safe and stable place to stay. And also thinking about people who might be fleeing violence, and other, unsafe situations, it really was a barrier to access. And so we definitely recommended sort of a simpler homelessness verification process that consider that there's sort of this spectrum of housing insecurity that goes beyond what may be on legal sort of paperwork. And then next, a major sort of, finding was that pregnant people said, hey, it's difficult to manage a pregnancy, particularly one with complications, and also maintain my basic needs. And so we sort of recommended specific care coordinators or case managers for pregnant individuals that were really well versed in resources available in the city, to not only help them, get their homelessness needs met, but also to meet their needs around health, hygiene, nutrition, transportation, safety. So this participant actually said to us, with diabetes, you're supposed to have multiple small meals throughout the day to keep your blood sugar at a certain level. I don't have a refrigerator that I can just tag along with me all day. It's also hard to get in small meals. Sometimes I would sit outside of certain restaurants all day just so I would be able to have just a little bite throughout the day. like outside of 7-Eleven, people would come past and give you random stuff, and that would help. Now I take metformin, but it's hard to keep up with medication. Somebody might steal my bag. And then now my medicine's gone all over again. So multiple situations, regardless of whether or not they're on insulin or taking metformin orally. Other findings. So clients who did receive housing assistance did not experience or perceive that they were on a pathway to long-term sustainability. So the way the DC housing system works is there's a number of programs that you can be eligible for, but some of them are time limited. So maybe you can get housed in a rapid rehousing program for say 9 months or a year, but then you have to move on to a new program. And so there were sort of all of these different stops along the way. You were never sort of in a final safe space that you could be in for a significant period of time. Additionally, there didn't seem to be among the clients sort of this perception that they were getting help to increase their stability in other ways, job assistance, mental health resources, cash support. So, are there ways that we can really, one, prioritize housing that includes minimal transitions, and also invest in programs that support pregnant people and parents in other needs that they have, ultimately to ideally set them on a path towards long-term sustainability. And then finally, a lot of the clients mentioned, unfortunately, a really disrespectful system, and feeling like their needs and, um, were not really taken into consideration, and that they were maybe not treated in kind and dignified ways. And so, one of our policy recommendations was to ensure respectful and responsive communication from homelessness assistance agencies and staff. So I think honestly, um, in any sort of, system in which you have constraints like time and resources, um, even in maternal health, right? We talk about sort of the lack of just general respectful care. It can be this very similar in other systems as well. Sort of establishing that culture of love and respect and compassion to guide you in your interactions. So this client really just said, be patient. For better support, you need to have a little more patience. That's all. A little more patience, and not act like you care, but actually care about the pregnant person that you're encountering. Okay. So now I'm going to be moving on. So that was one study, and but now I'm going to be moving on to sort of thinking about how we can redesign our healthcare system so that it's not so isolated from community. Sort of thinking about how community-based models of care can actually partner with the healthcare system to improve outcomes as well. So I'm currently conducting a Delphi study that's focused on promoting Black maternal health equity through equitable partnerships between community-based doulas and healthcare systems. And so this study was undertaken in partnership with Black Women's Health Imperative, which is sort of a long-standing um, organization based in DC and Atlanta, really focused on sort of what are the health needs of Black women. And they are very much interested in maternal health, of course. And the study was funded by the Institute for Policy Solutions at the Johns Hopkins School of Nursing. And so this study really focuses a lot on doulas, which I think have been in the news quite a bit, as far as the impact that they make and also their potential for helping us think about how to provide better care. So there's actually quite a bit of evidence related to doulas, increased rates of vaginal birth, increased breastfeeding initiation, exclusivity, duration, and improved satisfaction with birth. There's also an a general movement towards more fully integrating doulas into the healthcare system, particularly into Medicaid. And so this map, it's accurate as of February 2024, but you'll see that the red stars actually indicate states that are actively providing some level of reimbursement coverage for doula care for a range of perinatal services. Um, Usually there's some sort of package, either a la carte and or package of services that's covered in these states related to, several prenatal visits, the birth and postpartum. And so there's really a lot of momentum around thinking about integrating doulas into our, healthcare reimbursement system. There, as you can see, the yellow stars are states in the process of implementation, and the blue states are states with related or adjacent action. So maybe they're sort of just starting to think about ways to incorporate doulas into their reimbursement models. Um, but doulas are really, I mean, this is kind of groundbreaking in that doulas are sort of non-medical professionals, right? They provide that informational, physical, emotional support, advocacy support. Um, that really has been missing. But most individuals who are eligible for reimbursement under Medicaid have to have some sort of license, right? So this is sort of a new focus for funding and for policy reform. But there are also other ways that doulas are being integrated into the healthcare system. And I was really interested in thinking about, okay, how can we promote Black maternal health equity through this? And what are the research priorities? I definitely recognized that there are doulas who are leading this work. Um, and so I feel like my place was more in terms of how can we use research to, to give us the data that we need to point us in the right directions into how these partnerships can be developed in equitable and impactful ways. And so through our Delphi study, we have convened an expert panel to identify research priorities for promoting Black maternal health equity through equitable partnerships between community-based doulas and perinatal healthcare systems. And I'm largely focused on the Mid-Atlantic region. So sort of thinking about New York, Pennsylvania, Delaware, Maryland, DC region, Virginia, etc. And so this is a 3-round Delphi study. The first study was actually an in-person cafe that we held during Black Maternal Health Week in April. And we tried to understand, what's the landscape of partnerships? What are the partnerships that are currently happening? Because a lot of states and a lot of organizations are partnering together. A lot of institutions are partnering with organizations and individual doulas as well. So what's sort of the landscape of partnerships that are happening? And what do we need to get to the place where these partnerships aren't extractive or harmful to doulas, right? Who have legitimate concerns around sustainability and equitable pay. But what can we do to create sort of equitable partnerships where patients can benefit from partnerships where doulas are equitably compensated for their work? So I want to share one sort of graphical image of of the work that we did that day. It was sort of a full day of um, of utilizing discussion, small group work. We actually utilize something called the World Cafe model, which is where you have sort of short bursts of conversation around specific questions. And then you sort of harvest the information out to the entire group. And so during our harvest, we had a graphical illustrator that sort of provided us with a summary of what we found during that day. And what we found is that there is just this really fertile landscape of partnerships that are happening between doulas and healthcare systems. Doulas are working with medical education programs to provide sort of information about what is a doula, raise awareness and knowledge among medical residents around doula work, so that there can sort of be this, ideally, this increased awareness, but also this mutual respect as well. There's new sort of apps and companies that are emerging that help doulas to navigate the administrative burdens associated um, with applying to become credentialed with Medicaid so that they can be reimbursed for their care. There are doulas that are focused on special populations like those that are survivors of violence, those that may have been incarcerated or are currently incarcerated as well. So there's lots of work that's being done in sort of the very formal healthcare spaces, but also in spaces that are sort of, less formal, more informal, prisons, home visiting programs, violence organizations, but where doulas are really making an impact as well. So at the end of our time together, we had sort of this image along with several others that described our day. We have since analyzed our data, and we are now in the works of finalizing sort of the survey that is going to form the basis of the second round. So we had a qualitative first round to really sort of brainstorm, generate ideas about sort of what are sort of the important topics that we could research potentially. And now we're going to have people sort of rank these research priorities that we've developed. And so stay tuned. Round 2 and 3 are launching this fall. Um, and we hope to share our results widely as well. Okay. So I have one last research study that I want to share with you all. This research study is really just starting, and so I'm just going to sort of give you a sneak peek about what I'm doing. But the focus is on using a collaborative human-centered design to develop a postpartum intervention for Black birthing people with hypertensive disorders of pregnancy. And so really the purpose of this is to actually design a midwife-led intervention that can improve postpartum hypertension outcomes for Black women and birthing people with hypertensive disorders of pregnancy. And this is really important, I think, for this group because Black women and birthing people are over twice as likely as their non-Hispanic white counterparts to experience hypertensive disorders of pregnancy. So that could include chronic hypertension, gestational hypertension, and also preeclampsia as well. And this is significant because it increases the risk of postpartum hospital readmission. They're more likely to remain hypertensive through 12 months postpartum. And when you think really long term, there's an increased risk of cardiovascular disease and stroke later in life as well. And so I'm really focused on the postpartum period. As you can see, this is data from the CDC that talks about sort of the timing of US maternal and pregnancy related deaths between 2011 to 2015. And what do you notice? A little bit over half of the deaths actually occur in the postpartum period, and not just in those first 6 weeks, right? That's up through 42 days, but even beyond that as well. And hypertension is one of the leading causes of maternal death as well. Now, current approaches really focus on remote blood pressure monitoring, which has been shown to be effective at reducing inequities in surveillance, but not necessarily effective at reducing inequities in postpartum blood pressure control through 12 months postpartum. And so there's really this need to develop interventions that address sort of the root of what may be causing these disparities. So racism um, and how it manifests in interpersonal reactions, but also structurally as well. So I'm really guided by sort of Black feminist thought in this work. because I think that when we consider, how do we make systems change for Black women, we have to really be grounded in what's the historical and sociocultural context that that arcs over generations for Black women, because that is going to give us the insight into changes that need to be made um, as well. So I'm actually going to keep going because I think I'm running out of time, but I wanted to share that we're using human-centered design, which really focuses on the users, but not just the users, but also anyone that might be involved in sort of delivering an intervention as well. So ultimately, we'll be bringing together patients, but also healthcare providers, doulas, other perinatal community support workers that are going to be integral into providing an intervention that's meaningful and culturally tailored. So these are our partners. I'm working with Unity Healthcare, again, FQHC, and Mama Toto Village, which is a Black-led perinatal wellness center in Washington, D.C. And they provide doula care, but also just overarching perinatal community support as well in a multitude of ways. And so I'm really happy to be working on thinking about how this partnership between a healthcare institution and an organization that certifies and provides doulas can improve care. So to design this intervention, we are first going to describe the postpartum care experiences of Black individuals with hypertensive disorders of pregnancy in federally qualified health centers, making sure to articulate the ways that racism, structural racism, influences their journeys and impacts outcomes. And then second, we'll be developing a prototype of the intervention that addresses structural racism and builds structural resilience. And so we'll be doing that by doing patient journey mapping sessions. So those are planned for September and October. And we plan on developing a visual depiction of the patient journey that will help us understand, okay, what are sort of the opportunities and the challenges that are represented by the current state of how Black women experience care when they've been diagnosed with a hypertensive disorder in pregnancy, and how they experience it not just in pregnancy, but also through the first year postpartum. And then in November and the first week of December, we'll be doing 2 co-design sessions where we will be developing intervention prototypes to understand, hey, what do you all want to see? What would have made your experience better, and what would you like to see for other Black women and birthing people to receive as well? So stay tuned. Hopefully next year I'll be talking about this intervention that I have developed along with my partners and my research team. Um, and thank you all for listening, and feel free to contact me and get in touch. And let me know if you have questions.
Thank you. Thank you, Nolene. That was fabulous. Such interesting work and so important. And I just can't get over, it's like you're using methods that I'm sure people in the social sciences or in other fields use, but that we don't often use in, traditional biomedical and, public health research, especially these sort of human-centered design and these Delphi methods and things like that. And so I think that really helps to ground your work in sort of, you know, what you just said about bringing the voices of people who have been marginalized, elevating their voices and making sure that we're really addressing their needs appropriately and are mindful of all the myriad factors that are contributing to the current situation. So I have a question that may seem a little bit uninformed, so I apologize, but um, how do you see the work that is going on with doulas as being related or distinct from the work that you described earlier on with midwives? Do you see like are they parallel? Are they interconnected in some way? What are the distinctions in those?
Thank you. And are you referring to my work specifically, or sort of the larger dynamics
Um,
when
well,
it comes to
you can
perinatal?
comment on both, but but I think I was interested in your specific work, but I mean, I'm sure that the broader context has something to do with that too, right?
Yeah. Um, I think there's definitely some overlap.
Mhm,
I mean, I think first of all, a lot of people don't know that doulas and midwives, either exist,
mhm,
or second, they think that doulas and midwives are the same thing, that they provide sort of the same
mhm,
support, right? But we know that midwives are sort of health professionals who are providing medical care along the spectrum, midwifery care along the sort of reproductive spectrum. And doulas are providing much needed informational advocacy, social support.
mhm,
But there's a lot of parallels. I mean, I think for when we think about the perinatal workforce,
mhm,
midwives have just not had the same sort of traction here in the United States for some of the historical reasons that I already mentioned.
mhm,
Whereas doulas sort of had a slightly different trajectory. Um,
mhm,
they sort of started to emerge, in the 1960s, 1970s as a very sort of spontaneous way to support women in pregnancy and childbirth, and oftentimes very, very much tied to the women's movement, which sort of tried to, at one point, get more control in their pregnancy and childbirth experience. And so doulas now are experiencing sort of this professionalization shift that's happening, where, now there's talk about creating standards for doula certification. There's discussion around, how they can be integrated into the healthcare team. Whereas midwives are sort of already on the healthcare team, but our model of care, our philosophy of care, isn't really sort of, valued and at front and center. Um, so there's a lot of parallels, but definitely sort of this distinct
mhm,
emergence, and existence of both of these professions. I would say in my work, I think about the midwifery philosophy of care as central to changing how we approach pregnancy and birth and reproductive care for everyone.
mhm,
Um, and think that if we grounded ourselves more in sort of the principles related to midwifery care, that the care for, many individuals can be improved.
mhm,
Um, Now, in terms of doula care, I think that, this idea of sort of support has really just been, cast to the side, right? Think about sort of COVID when, hospitals, they sometimes made people go to birth by themselves in the hospital.
mhm,
And it's because we don't value sort
yeah,
of the idea of support and how crucial it is to, to healthcare.
mhm,
So I sort of, see these things as similar but different. With
yeah,
midwives, I think it's sort of about a philosophy of care that we can sort of infuse into the system, and doula sort of an additional support system that can be created as well. Um, Now, I'm not a doula, so they may have their own ideas about sort of, a philosophy of care that doulas provide as well.
yeah,
That could
yeah.
be beneficial too.
I understand. It sounds like that with despite the distinct challenges that there are, of course, there are some unique contributions, then that they could actually um, sort of work together to bring about some of the changes in maternal health care that we're looking to see, you know.
Yeah, and I think that with my work on the last intervention that I mentioned,
Mhm.
it's the plan is for it to be sort of focused on midwifery care and sort of dyadic visits with the birthing person and their infant as a way to sort of increase surveillance and touch points where we can make sure that medication management and lifestyle education is happening in the postpartum period, but also provide linkages to sort of Black-led doulas, Black-led organizations like Mama Toto Village. So definitely some collaboration is important.
Mhm. Are there other questions from the floor, from the platform? There were a lot of great comments coming in about the importance of your work and um, sort of people identifying with some of the things that you found and giving you kudos for the qualitative methods and remarking about some of the similarities and some of the issues to the issues we see with the community health worker workforce as well. So, and it sounds like you've got several colleagues in the audience who have put some resources in the chat as well. So if there aren't any other comments or questions, I would love to thank Dr. Nolene Jeffers for a very provocative and um, sort of thought-provoking presentation of her work. And we're looking forward to hearing about the next steps and your findings. And just congratulations. And you've, I think, opened our eyes to some new methodologies and approaches when it comes to doing policy relevant research and community engaged and community partnered work in this space that uplifts justice, and principles of justice and equity. So thank you so much for giving us a wonderful start to the academic year. So those of you who are still on, we had up to 75 people on at one point. Don't forget to complete the survey I don't know if Lauren got a chance to drop that link in the chat or not. And if not, we look forward to seeing you all next month. We have Dr. Andrew Anderson from the School of Public Health who will be speaking. And so stay tuned. And we look forward to seeing all of you. Thank you so much, Dr. Jeffers.
Great, thank you.
So let's see.